Thank you, Ellen. Hi, everyone. Thank you for joining us today. I am Michelle Bowes, the CMS Regulatory Compliance Team Lead, and today we are going to talk about keeping up with all the rules that have recently come out. So first on our agenda is the Patients Over Paperwork Initiative, and I wanted to start with this. It's not technically a rule, it's an initiative that was launched by our president earlier this year, along with a couple of other initiatives. And basically, talking about this first will help us to understand the direction that CMS is taking some of the other regulatory programs. So after that, then we'll launch into the 2019 IPPS final rule, which is basically applicable to hospitals. However, that being said, a lot that has been finalized in that rule does apply to what they're proposing in the 2019 QPP proposed rule. So there is a trickle-down effect happening here, which is why we have decided to use this particular order in today's webinar. So again, before we jump into the rules, I want to take a moment to reflect on the state of healthcare today. With all the government-imposed red tape, confusing programs, and increased technical requirements put on vendors and providers to collect data, provider focus has been taken away from patient care. CMS's solution to this is their Patients Over Paperwork initiative. So I just want to read through the definition of this and then we'll elaborate a bit more about what this means. Through Patients Over Paperwork, CMS established an internal process to evaluate and streamline regulations with a goal to reduce unnecessary burden, to increase efficiencies, and to improve beneficiary experience. In carrying out this internal process, CMS is moving the needle and removing regulatory obstacles that get in the way of providers spending time with patients. So basically, we're looking at a problem where the focus has been taken away from patient care. And as you can see up above, this is a quote from CMS, that for every hour a provider sees patients, they spend nearly 2 hours on paperwork. So the solution that they've come up with is this initiative to ease burden and focus on patients. So through this initiative, CMS aims to improve outcomes, lower regulatory burdensome requirements, decrease costs, and improve exchange of information. Also included in this aim are specific directives that maybe you haven't heard about but need to. So I just want to touch on those quickly before we move on. So the first one is documentation requirement simplification. At this point, these are change requests submitted to CMS and or clarifications about specific documentation. CMS is also requesting your input on how to reduce documentation burden. So the second directive is E&M reform. CMS is implementing changes to the way you select and code E&M visits. This also affects your Medicare reimbursement. If this is new to you, if you've never heard about this, please go visit the reference sites on this slide to go learn more. The last directive is the Meaningful Measures Initiative, and basically this is the baby brother of the Patients Over Paperwork Initiative. This is an effort to make sure that the data you collect and measures you report for promoting interoperability and quality, support improvements in patient care, interoperability or the sharing of patient data, and align measures across platforms. Again, I've put links for all of the initiatives and directives on this slide so that you can go out and self-educate. So we're beginning the rule discussions with the 2019 Inpatient Prospective Payment System Final Rule, because most of what has already been finalized for hospitals in this rule for 2019 is also proposed for clinicians under the 2019 QPP proposed rule. So first of all, I just wanted to quickly go over the major changes that have been finalized for hospitals in 2019. First of all, Meaningful Use, or MU, or the EHR Incentive Program, is now officially called Promoting Interoperability, or PI. You're going to see me use PI throughout the slide deck, so please know that PI represents Promoting Interoperability, which again is the new MU. So also under QPP, the ACI category is now PI. So MU equals PI and ACI equals PI. Now they are one and the same. Secondly, interoperability is an inherent requirement to meet the needs of this new healthcare ecosystem. So a lot of the direction that CMS is taking is toward this goal of sharing data. And what they want us to understand that sharing of data is now inherent to healthcare. It is not something you do to meet a program requirement. It is simply something that you must do. Secondly, under the 2019 final rule, the security risk analysis continues to be required. Now, I say that because, as you'll learn here in just a few minutes, the methodology for scoring the PI objectives has changed. One change in that is that security risk analysis isn't even part of the score. It is simply a requirement. So continue to conduct your annual security risk analysis. They will be required for you to even submit an attestation. Thirdly, the minimum 90-day reporting period for promoting interoperability and ECQMs for hospitals will continue in 2019 and 2020. Also, in 2019, the 2015 certified EHR is required. So this is no longer an option. You don't get a bonus if you've got a 2015 ONC edition EHR. It is required. So if you are on a vendor system that is not currently certified to the 2015 version, please discuss this with them so that you understand when you will start to receive that upgrade. So in 2019, there are brand new and changed PI objectives. So we have objectives which are the highest of the tier. Within some objectives, you have measures. You might have one, you might have a couple. And then we've also got some measures that were removed. And again, like I mentioned earlier, there is going to be a new performance score methodology next year, and it will be much like the quality payment program is already for the ACI/PI category. All right, so let's go into the final rule for hospitals for promoting interoperability. Again, the reporting period for promoting interoperability is a minimum of 90 days up to a full calendar year. The performance score is a minimum of 50 points. Now, let's talk about the performance score a little bit. It used to be that each objective had a threshold to meet. And if you were above that threshold, then you could submit your attestation. This is changing for 2019. So in 2019, if you're a hospital, you still have your objectives, you still have your measures, but each measure will be granted its own set of maximum points that you can achieve. So the total performance score that you can achieve is 100 points. Now, what is not quite clear yet is how they will apply the points to the percentages. With QPP, basically a point is assigned for every 10% that you get on a measure, and for those that are worth more points, of course, there is a ratio there that would be applied. So that's something we still have yet to learn. The fact sheets have not yet come out on those, so we will be but you will see on the right side that we do have only 4 objectives, but under each objective are different measures. So under e-prescribing, you're going to see some new measures. You're going to see some new naming conventions. And of course, you're going to see the maximum points available for each measure. And we'll dig into those in just a little bit. And again, you don't see the SRA on here. So your security risk analysis is not part of the overall performance score. It is simply a requirement. All right, so let's get into the objectives that have been affected with the 2019 final rule. So e-prescribing is the first objective. Basically, e-prescribing remains the same, where you are querying for a drug formulary and you're sending that script electronically to the pharmacy. What is new for 2019 and 2020 are the addition of 2 measures. So the query of PDMP which is optional in 2019 and required in 2020, holds a 5-point bonus for each year that you are participating. There are going to be some exclusions applied to this measure. The second measure that has been added is to verify opioid treatment. Again, this is optional in 19 and in 2020. And again, this is a 5-point bonus for each year that you participate. These are optional in 2019, but you do get bonus points if you participate. All right, the second objective we want to review is the Health Information Exchange, or HIE objective. Under this objective, there were a couple of measures before, and these have changed a bit. So the first one that was previously named Send Summary of Care is now named Support Electronic Referral Loops by Sending Health Information. This is a 20-point measure, and there are no exclusions for this one. The second measure is one that actually combined two historical stage 3 measures. So it's taken the Request Accept Summary of Care and the Clinical Information Reconciliation and mushed them into a new measure called Support Electronic Referral Loops by Receiving and Incorporating Health Information. And this is also a 20-point measure. So some of these measures do have exclusions where the points that are assigned to that measure are reweighted to other measures. This is something that we will probably have a follow-up webinar on to really dig into what this means for the scoring methodology that will be new for 2019. So the coordination of care measure has actually been removed. Now, this objective and these measures have been flagged for removal in the 2019 IPPS final rule, but I want to caution you here. CMS has pulled this trick in the past where they've declared the removal of an objective or measure from a program, when in reality, they just tucked it into another objective. The CMS fact sheets for the 2019 Promoting Interoperability program have not yet been released, but as I said earlier, we'll be monitoring the Promoting Interoperability CMS website closely so that we can investigate these 2019 objectives thoroughly when they're available. Again, this particular removal only applies to hospitals at this point, and take this removal and the information that I've just given you here with a grain of salt, because this stuff is likely to change when the fact sheets are released. Okay, the next objective I want to cover is the Provide Electronic Access. So the Provide Electronic Access, the objective is now named Provider to Patient Exchange. So the overall objective has a new name, and then the measure, which was Provide Patient Access, is now named Provide Patients Electronic Access to Their Health Information. Now, under this one previously, when it was stage 3, before this final rule came out, education was part of this objective. Now they say education has been removed. Again, I want to take this with a grain of salt, wait for the fact sheets to come out so that there isn't a misunderstanding that education is still part of this, but not separately measured. All right, the next objective is public health. And again, the public health objective has a new name, that is Clinical Data Registry Reporting. This one is worth 10 points. It works basically the same as it has for modified stage 2 and the old stage 3, where we've got certain exclusions that apply to certain registries or certain providers in certain areas where perhaps a service isn't available or something like that. So some of those exclusions still remain. Basically, what's changed with this measure is that a hospital or critical access hospital can choose 2 measures. You must submit a yes or no or an exclusion response during your attestation for 2 measures. If you submit a no, it will automatically fail the hospital from the Promoting Interoperability program. Now again, there are exclusions, and a hospital can claim an exclusion for 1 measure and attest a yes to another measure and still earn the 10 points. If a hospital claims exclusions for any or both measures, Those 10 points will be redistributed to provide patients electronic access to their health information measure. All right. We're actually going to switch gears to the Quality Payment Program, otherwise known as the QPP. Now, if you're unfamiliar with the QPP, we've done many webinars and blog posts in the past on the program, and I strongly encourage you to visit our website. I've posted it there at the bottom of the slide to learn more. You can also visit the CMS QPP website. They've done a really good job about keeping things updated there and providing great educational resources as well. So, as a quick review, there's multiple ways to participate in the QPP, the most popular being through the MIPS track and the other through the Advanced Payment Model or APM participation track. All of you on the line today, as long as you're eligible, will submit in one of these ways to the QPP. Now, this year, most eligible groups and eligible clinicians will submit information under the QPP MIPS transitional requirements. There are some of you on the line that are part of ACOs. This still applies to you because as part of an ACO, they're extracting the quality metrics for you and submitting them on your behalf, but you still have to submit your own ACI/PI attestation to the QPP website. So this year, those transitional ACI or PI objectives are what you'll submit. Now for 2019, we've got some new requirements. So the 2019 QPP proposed rule came out in early July. And like the hospital rule, there are many changes. Again, these slides that I'm about to present to you are only what has been proposed, and these could change with the final rule that's slated to come out in October. So much like the Promoting Interoperability program that replaced the HR Incentive or MU program for the hospitals, the QPP ACI category has also been named Promoting Interoperability. In 2019, new quote-unquote Stage 3 objectives are required, as is the 2015 Certified Electronic Health Record System. So that is a requirement across the board for anybody participating in these programs. New eligible clinicians are required to participate in 2019. Are you on this list? So under the QPP program, there are 4 categories, and each of those categories in 2019 have new weights. There are also new reporting periods, new submission methods, and clinicians and groups would also have the option of opting in or voluntarily submitting data to the QPP. Also in 2019, for those clinicians or groups who see more than 75% of their patients in a hospital, outpatient, or emergency room setting, the hospital-based ECs could utilize facility-based scoring for their quality and cost metrics. We'll get into that here in just a little bit. So for 2019, there are new eligible clinicians that must be folded into your QPP program participation. So as you can see, in 2018, again, this included physicians, PAs, NPs, nurse specialists, and CRNAs. In 2019, these new eligible clinician types will include physical therapists, occupational therapists, clinical social workers, and clinical psychologists. Now, I also wanted to focus your attention on the next column. So in the proposed rule, they are considering including these clinicians. Now, what will determine if these clinicians are folded into program participation is if CMS determines that these eligible clinicians would have at least 6 of the MIPS ECQMs available to report on. So if they end up getting rid of a bunch of ECQMs, which results in a smaller set that wouldn't necessarily apply to these clinicians, they could throw these out. But if they leave enough applicable ECQMs available, they might decide to fold in these eligible clinicians, which makes them part of your group, required to individually report, and something that we really need to monitor closely. All categories have been newly weighted for 2019. Quality now represents 45% of your total performance score, promoting interoperability 25%, cost 15%, and improvement activities 15%. In addition to new category weights, nearly every category has changes proposed. So for quality, they're considering adding at least 10 new CQMs and removing 34. Additionally, they've identified new collection types and submission types. We'll get more into that in a little bit. For promoting interoperability, as discussed earlier in the 2019 IPPS final rule or hospital final rule, CMS is aligning PI objective and measure names across the board. Also new for 2019 is the minimum performance score of 30 under the QPP program. And this is up from 15 in program year 2018. And the exceptional performance score goes from 70 to 80 in 2018. As mentioned earlier, 2015 Certified Electronic Health Technology is also required, as are new eligible clinician types that we just reviewed. Cost is increasing its weight from 10% to 15% in 2019, but at least they've steered away from the 30% weight that was originally proposed. So cost is calculated off Medicare administrative claims and benchmarked currently on 2 episode-based measures. In 2019, they're proposing to add 8 measures, each weighted separately for a total of 10 measures and a total score of 100. Improvement activities is really the one category that's remaining unchanged, so we won't be talking about that too much in this webinar. Okay, so let's just touch quickly on the proposed data collection and submission mechanism changes. So I think basically what CMS wanted to do here was define some terms. So the first term that they have outlined is the collection type. And basically this is the CQM collection method. So where is it being aggregated? Is it in your EHR? Is it in your registry, etc.? So for 2019, these are the identified collection types: your CQMs, which is your EHR, your MIPS CQMs, which is your registry, your QCDR, or your CAPS for MIPS survey, or your CMS web interface measures. The mechanism number 2 is your submission type, and this is how a submitter submits data to CMS. So these would include direct, which is basically the submission of information directly from your EHR to the QPP. There is login and upload, and login and attest. Basically, both of these are utilizing EIDM credentials to upload your QRDA file, attest to PI and practice improvement categories, etc. Then there is the CMS web interface that groups of 25 or more ECs use to upload and attest to information. Now they are proposing to reduce this to groups of 16 or more also, so this could change a bit. And then also claims. So claims has historically been a way to submit quality information for individual clinicians. And again, in 2019, there is a proposal to include small group practices in this, where a group can use claims information to submit quality. The third mechanism is the submitter type. MIPS eligible clinicians, groups or virtual groups, or third-party intermediary acting on behalf of a clinician or group that submits data. So basically, what's your strategy for submitting? Are you a group? Are you an individual clinician? Are you using a third-party intermediary to work with you? And that would basically be your virtual group as well. Okay, I just wanted to upload these tables direct from the proposed rule so that you can kind of have a visual on what this means for the categories, because each category has its own submission type, its own submitter type, and collection type. Some of it's not applicable to a specific category. So this first slide is for individual eligible clinicians. So if you just have one physician, one MP that's submitting to the quality payment program, here are your options for these different mechanisms. Likewise, I uploaded the table directly from the proposed rule for groups that are submitting to the quality payment program. So these will be part of the slide deck that is made available to you. We're not going to really dig into these in depth right now, and really not a lot has changed except for the definition of these mechanisms. Okay, so promoting interoperability is again the new ACI category name under the QPP. Now, we knew that in 2019, the QPP PI program was going to require the quote-unquote stage 3 objectives. CMS has changed, morphed, and removed some measures, much like they have in the 2019 hospital final rule. So they're basically using the same objective weighting system as the hospital final rule, which takes into account a max score of 100 for the PI category. Now, what is unclear is if they'll stay with the benchmark of the percentage to point system, or if they'll come out with a new benchmarking system. Again, this is all proposed, so this is to be determined. What is clear is that the EHR vendors have some work to do to make sure that their QPP reports reflect all the changes for promoting interoperability and that they include all of the new eligible clinicians. The quality category is undergoing quite a few changes. First, the proposed reporting period for program year 2019 and 2020 is a full calendar year. Next, in 2019 is the option to collect data from multiple avenues like claims and EHR. So historically, if we're reporting to a category, you could only use one method for collecting data. Let's say you used your EHR QRDA file. So in 2019, they are allowing multiple collection and data submission options. They're also considering a new tiered scoring process for quality based on the value of a measure. I don't think it's essential for us to dive into this right now. We're going to wait until the final rules are released and have a better idea of exactly what this means. They're also reducing the small practice participation bonus in 2018 from 5 to 3 in 2019. Next, data completeness will be set at 60%, and this is up 10% from 2018. Basically, this means that for each quality measure selected, a minimum of 60% of the total eligible instances must be reported. And this is especially important for a hospital system. So let's say you are all operating under a single tax ID, you're planning to submit as a group, but you cannot aggregate QRDA files out of two different EHRs. So it's up to you to decide where at least 60% of the total eligible instances are originating. Are they coming from your clinic? Are they coming from the hospital? Are we going to be able to hit that 60% threshold with the use of one or the other EHR QRDA file? Also new in 2019 is the option for hospital-based clinicians or groups to utilize the hospital value-based purchasing program metrics in lieu of reporting their quality and cost categories. Again, this is just proposed. There's a lot of information about this, and I know we have a lot of hospitals on the line who are participating in QPP and are going to be really interested in this. We will circle back to this particular proposal once the final rules are released. Next, if you are a group of 16 or more clinicians, CMS is proposing the reduction of the number of ECs in a group who utilize the CMS web interface reporting to go from 25 to 16. Lastly, they're considering adding 10 new MIPS measures and removing 34. So the cost category is new for everyone this year at a weight of 10%. In 2019, they're proposing to increase this category weight to 15% and add 8 new episode-based measures to the existing 2 measures for scoring. Let me show you what that means. So this slide lists the 8 proposed measures and how the cost performance score is calculated. So each measure would have a weight of 10 points, with 100 points being the max performance score available for the cost category. In this category, each measure has a cost scale and a decile point assigned. Basically, the lower your cost is on the cost scale, the more points you'll get. this is confusing, I have something for you to see that might clear this up, and it is your 2017 cost category information that is now available on the QPP website for all non-ACO participants. So if you participated in MIPS in 2017, your cost information has already been scored there. Now, the 2017 cost category had a weight of 0, so that did not affect your score for the 2017 participation year. However, logging into the QPP to see where you stand in this category and what your score is for the cost category will be beneficial to you when anticipating your 2018 cost category score. So here is a screenshot of a real cost category analysis, and you can see the 2 episode-based measures for which you were scored. So the first one being your MSPB, your Medicare spending per beneficiary, and your total per capita cost, your TPCC. Each score has a weight of 10, and as you can see in the benchmark data, the lower the cost, the higher your score for that particular measure, and the higher your score overall, the higher your category score, which improves your overall MIPS performance score. There's some information over on the right as well about your eligible cases or episodes, exactly where you're averaging on cost per capita or per episode, your ratio, and the points that you're earning for each measure. Again, this is available on the QPP website. Log in with your EIDM credentials, and you'll be able to go view this information for 2017. All right, so the next proposal for the QPP program in 2019 is the option for opting in or voluntarily submitting information to the QPP. Now, there's a difference here. Opting in requires a formal declaration submitted to the QPP website that is irrevocable. So if you decide to opt in and you tell CMS that, you can't change your mind. So the way that you can opt in is if you, as an eligible clinician or a group, exceeds one of the 3 low volume threshold requirements, you can decide to opt in. So either you have more than $90,000 in Medicare Part B allowables billed in a single year, you have more than 200 Medicare Part B beneficiaries, or you have more than 200 covered professional services to Medicare Part B beneficiaries. If you have one of those, you can decide to opt in. And if you opt in, the MIPS adjustment factor applies, meaning you can have a penalty, you can be neutral, or you can potentially receive incentive money. Now, the second option for 2019 is to voluntarily submit information. Basically, you're submitting information to the Quality Payment Program just to kind of see how you do. Go through the process. Maybe you're not required, but you want to start baby stepping into participation. This is a good way to do that, where you submit your information, you go through the QRD upload, you attest to the PI categories and cost categories and improvement categories, and you see where you land. The payment factor does not apply to you, so you won't be penalized, you won't be getting any incentives, but it's basically a practice session. So on the heels of voluntarily submitting and talking about payment adjustments, let's go into that. So for fiscal year 2019, which was last year's program year, CMS exceeded the MIPS participation goal. So what does that mean? That means that they had more participants in MIPS that were successful participants than they anticipated. So the QPP MIPS program was designed to be budget neutral, meaning that the penalties that non-participants incurred would pay for the incentives that those that were successfully participating in the program would receive. The result of all this is that fewer penalties were assessed and more incentives were paid out. Unfortunately, the exceptional performers did not see the incentives that could have been possible with scores over 70. And instead, they saw an average of 0.68% to 2.02%. So for this year, in fiscal year 2020, the adjustments, either negative or positive, they're anticipating to be plus or minus 5%. Now there is a scaling factor that should be applied here as it was applied last year that is going to bring this down just a bit. And as we know, more people are gearing to participate. So the incentives here could be quite a bit less than the 5% that they are anticipating. Now for program year 2019 and fiscal year 2021, budget neutrality must consider the proposed changes here. So we've given the eligible clinicians and groups the option to opt in, which means those that perhaps were thrown into the low volume exclusion bucket in 2018 where they couldn't submit information to the quality payment program may decide to opt in, meaning there are more successful participants in the MIPS program than ever. There's also a scaling factor that needs to be calculated into anticipating what your adjustment could be. I did note that it is on page 811 of the proposed rule. It's one of these things that we're going to look closely at to help folks gauge what their proposed MIPS score could bring them for a true dollar figure using this scaling factor. I also need to consider that the minimum participation performance score is increasing from 15 to 30. So historically, if you had a score of 15 or more, you were either neutral and didn't receive a penalty, or you got just a little bit of a bonus. Now that minimum participation score is going up to 30, which could throw those folks that were participating at a low level back into the negative payment adjustment pool. And again, for fiscal year 2021, they are anticipating an adjustment of either plus or minus 7%. But we do need to factor in the scaling factor when looking at real adjustment numbers. So let's just take a few moments to review what it takes to participate in any CMS regulatory program. So submitting regulatory data to CMS requires a lot of important decisions, as we all know. Decisions that impact your score, which affect your reimbursement, which affect your reputation. That's why it's critical that decisions around regulatory program compliance start at the top. It is essential that leadership recognizes and supports reporting efforts, and that the value and importance of the programs are imprinted throughout an organization. Honestly, I've spent the last 10 years of my career working with hospitals and clinics to develop and support goals for regulatory program compliance. The organizations that have the leadership that understands the impact of these programs, leadership that implements clear directives of compliance and supports those directives with assignment of responsibility and empowerment to a team, whether it's an office administrator of a small rural health clinic or the executive leadership of a hospital, not only succeed, but excel and reap the benefits in dollar signs and publicly reported information that your patients now use to shop for healthcare, your competitors use to get the upper hand, and insurers are now using for negotiating fee schedules. So step 1, develop your team. It takes time and dedicated staff to drive cultural and behavioral change. Successful adherence to any regulatory compliance program means putting processes and people in place and sharing relevant data that will drive change with clinicians. So let's talk about that team. Your team needs to include technical staff, such as EHR super user, those that are responsible for updating and maintaining your EHR, your IT director, your HIPAA security official, and your interface manager. Your team also needs to include those responsible for educating your staff on a variety of information. Those would include program leads, EHR super user, clinical educators, those tasked with increasing workflow efficiencies, as well as a financial impact advisor. Your team should also include a representative from your administrative team, as well as a person or persons in charge of data collection, data integrity checks, and presentation to the team, and a person or persons who will report data to the program bodies. These could quite possibly fall on the shoulders of your program compliance team lead. Lastly, your team needs to include at least one representative from your medical or clinical staff who will be responsible for learning all the EHR data collection elements and workflows, who will ensure knowledge transfer to all staff happens and work with the team to troubleshoot gaps in expected results. This person will also work with the program compliance team lead to set goals for the program as a whole and for individual objectives. The second most crucial step to program compliance success is to learn everything you can about a program. Understand its backbone, its purpose, and its goals. These programs, whether new or old, are vast, and the sheer amount of information available from hundreds of resources and often cross-contaminated data supplied by CMS is dizzying and overwhelming. It can be a lot, but I strongly encourage you to do the best you can with all the resources available to you. Now, once your team is knowledgeable, make sure that they're sharing what they've absorbed. Knowledge transfer is absolutely essential. And I'm going to say it again, knowledge transfer is essential. Share the knowledge, share the resources, keep your team in the know. This is work that cannot be accomplished or continued in a single person silo. Knowledge transfer ensures your organization will continue to succeed in program compliance even when the unexpected happens. Step 3, plan and review your participation strategy. Have you identified which programs you could or should participate in? If you've been eligible for Medicaid, EHR incentives in the past, are you still eligible? And remember, you can participate in both Medicaid, promoting interoperability, and quality payment program at the same time. Also consider the consequences for none or low participation. What does that mean for your bottom line? What does that mean for publicly reported information? If you're eligible for QPP, will you submit as a group or as individuals? What stage will you submit to for 2018? So you do have options for 2018 to submit to the historical modified stage 2 or stage 3 measures. In 2019, you must submit to the 2019 PI measures. Do you need that system upgrade? In 2019, you have to have the 2015 O&C certified version for your EHR. This is not an option. If you do not have that version, you cannot submit to any of these programs. If you're a hospital, which attestation method will you choose? So you still have the option for using ED method versus OBS method. And lastly, engage your team in these decisions and this strategy. Next, let's go over what you need to do to get your information that you're going to need to report to these programs. So EHRs are meant to be used as designed. The workflows and the processes an EHR vendor teaches during implementation and training and later in the life cycle of the system are to be taken at face value. Now, learning these workflows that feed and trigger the scorecards or the reports is the final step to program participation success. You will not represent your incredible patient care in data form to these programs if you are guessing at these workflows. You must follow the specific workflows and document in structured areas of the EHR charts in order for it to gather the data that represents your patient care. So I want you to pause and think a minute about workflow as a piece of art. These workflows are not interpretive abstract paintings. You cannot meander around the EHR documenting willy-nilly how you think or how you would guess would be appropriate. Can you get the job done for patient care? Yes, but would this documentation be able to be communicated or reported? Not likely. So instead, think of these workflows as an elementary paint by numbers. You're still the artist, you're still documenting, but the EHR is telling you when, how, and what order to paint, or in this case, document, to get the results that you expect, that you can appreciate, and you can utilize for program reporting. One more important point is about retraining and reskilling your staff on the use of your EHR. I love the word reskill. It insinuates that you're not only polishing the skills you've already learned and implemented, but just replenishing or topping off that bucket full of skills. You're empowering someone to be more skillful. And in the high-tech industry, it is becoming commonplace that this retraining or reskilling should occur every 2 to 3 years that you're on an EHR system. And this is typically a joint effort between you and your EHR vendor, where they conduct a workflow analysis. You put together remediation plans for workflows. They specifically train based on your workflow analysis needs so that you can use the EHR to create efficiencies. And then, of course, for you to have an opportunity to update your training materials library so that you can empower new employees and retrain your own staff. Lastly, in preparation for the 2018 program year submissions, I'd like you to go test your access to the submission sites. So once again, I have provided many links within this webinar and within the slide deck for you to utilize. I want to make sure that you're empowered to go self-educate on any programs for which you plan to participate. We have a lot of information available on our website, azaleahealth.com, under the resources tab as well. And if at any time you have questions, concerns, need a little bit of help, please don't hesitate to reach out to our support team or to me directly. I'm always happy to give direction and assist with program compliance. Thank you.